Temporal arteritis, it's basically a vasculitis of large and medium sized vessels. It can lead to severe complications if left untreated, including severe vision loss. The pathophysiology is characterized by chronic inflammation of the blood vessels. Histopathologically, it's characterized by giant multinucleated cells, leading to the name of the condition, and the cause of the inflammation remains unknown. It is believed to be because of a combination of genetic susceptibility and environmental triggers. The clinical features of this condition include a headache that is described as a new or an unusual headache in quality. Patient can also present with scalp tenderness, basically scalp sensitivity or pain, particularly while combing hair. Patient also can complain of jaw claudication, pain in the jaw while chewing, and it's because of the inadequate blood flow to the muscles of mastication. Patient can complain of amaurosis fugax, that is transient visual obscurations prior to onset of severe vision loss, which is usually irreversible. Can also present with diplopia in case the cranial nerves are involved. Along with all these symptoms, the patient will have, you will have to ask for these symptoms, will have usually complaints of fever, fatigue, and weight loss, which are basically non-specific symptoms of inflammatory conditions. 40% of them have polymyalgia rheumatica. Now coming to arthritic ischemic optic neuropathy, which is the most dreaded complication of giant cell arthritis. It's characterized by sudden severe vision loss, and the fundus is characterized by presence of severe pallid disc edema. The underlying condition is occlusion or narrowing of short posterior ciliary arteries that supply the optic nerve head. And typically the patient will say that there is a graying out of vision, which can occur over days to or it can be even in a day. And the vision loss is irreversible, hence it's an urgent condition, we need to act immediately. So how does one diagnose? The diagnosis is basically, one needs to suspect depending on the patient's symptoms, and once suspected, immediately ask for ESR and CRP, which usually are elevated in giant cell in temporal arteritis. But the gold standard to confirm the diagnosis remains temporal artery biopsy, which has a specificity of 100%, though it has a sensitivity of 77%. So the temporal artery biopsy should be done as soon as possible, ideally within 2 weeks of starting steroids. So one should not withhold steroids for doing TAB. You can do the TAB even after starting steroids for around 2 weeks. The length that is required to be harvested has been variably reported from 5 millimeters to 3 centimeters. British Society of Rheumatology says we need at least 1 centimeter of the length of temporal artery because of the presence of skip lesions. The other ways one can diagnose this condition is you can use Doppler ultrasound, which has the sensitivity of 67% only, but has a good specificity of around 95%. What do you see? You see a halo sign, which suggests the inflammation of the arterial wall, and you can confirm the diagnosis of GCA. Other more expensive ways of confirming the diagnosis are CTA and MRA, along with PET CT scan, but these have lesser specificity than the ultrasound. Coming to the management of AION, we all know that it should be immediately treated with high dose steroids, and the typical dose is 1 to 2 milligrams per kg body weight if you're giving oral steroids. And in case there is already arthritic ischemic optic neuropathy with severe vision loss, one needs to give intravenous methylprednisolone 1 gram per day for 3 to 5 days. In case the patient cannot tolerate steroids or needs prolonged, has been on prolonged steroids and experiencing side effects, one can consider methotrexate, tocilizumab, and azathioprine. But if the patient is kept on steroids, one important point is these are elderly patients that are being kept on prolonged steroids. One must monitor these patients for side effects of steroids, which include osteoporosis, hyperglycemia, and hypertension. And prophylactic measures such as biophosphonates for bone health should be proactively given. And frequent follow-ups with the rheumatologist are advisable. So what's the prognosis of AIO and GCA? One should be aware that this condition can have recurrences and relapse. And the long-term outlook can become very poor if there is a bilateral vision loss because of arthritic ischemic optic neuropathy. So let's look at this case. This 81-year-old lady presented to us with a history of very sudden decrease in vision in the right eye while reading newspaper. And she had a history of headache, loss of appetite, and jaw discomfort. She was treated elsewhere. She was diagnosed as central retinal artery occlusion and was treated with paracentesis, and she recovered a visual acuity of 3/60 in the right eye. She had a good vision in the left eye. Her visual field, you can see, is constricted on the right side. Left eye, it's good. So the patient was diagnosed as CRAO and was asked to follow up with the cardiologist, but she came to me for a second opinion, and looking at her symptoms of new onset headache, jaw claudication, I ordered for ESR and CRP. ESR was elevated, it was 75, but CRP was within normal limits. In view of the symptoms and elevated ESR and CRAO in an elderly, I sent her to a rheumatologist who asked for a temporal artery biopsy, which showed inflammation of intima, inflammation of vasa vasorum, fragmentation of internal limiting membranes with a few multinucleated giant cells. And there was also calcification of media, which was not a feature of GCA. There was calcification of media, which was a feature of Monkeyberg calcification of the media. Why we are looking for this diagnosis? Why I want to confirm? Because there is a question of saving the other eye, which will require steroids in case it's a GCA. So biopsy has kind of given the diagnosis that it's GCA, but with Monkeyberg calcification. So the case dilemmas here were that CRAO is an atypical presentation of GCA. Patient presented with that. Patient had a normal CRP, and even the histopathology got confused with the presence of calcification and Monkeyberg calcification. But we remained focused to the diagnosis. Patient did have GCA and was treated for the same. So in conclusion, arthritic ischemic optic neuropathy is a severe vision-threatening complication of GCA, and it can also present as CRAO and cranial nerve palsies, where the patient will present with diplopia. Prompt diagnosis and immediate treatment with corticosteroids are critical to prevent further vision loss in the other eye. However, once the vision is lost due to AION, generally it's irreversible. Hence, one needs to be very proactive in management. Thank you.